be here to tell you about some of the things that, whoops, that changed it. Some of the things I've learned over 40 years of watching children eat. The presenter view, whoops. Sorry.
Try and hide the presenter view. Okay.
No, now it's just a minute. Sorry. We had it all lined up.
Yeah, show presenter.
There we go. Okay. So like Jeanette, I feel a little uncomfortable telling you guys what I know about feeding, because you probably know a lot more than I do about feeding and the intricacies of all the physiological coordination. But some things that you may not know is that 11% of all preterms, regardless, as long as they're less than 37 weeks, 11% of them do have some feeding problems. And that number is higher in those who have chronic lung disease. So of children with feeding problems, a full third of them have some chronic lung disease. A quarter of those who are less than 1,500 grams have feeding problems. And of course, this number is really important to all of us. 80% of children with neurodevelopmental concerns have a feeding difficulty. And that just speaks to the complexity of the feeding problems and how children need to learn how to coordinate all of the processes related to eating. But the vast majority of babies over 28 weeks gestation or more do achieve feeding near term. So this slide simply tells us about all of the factors that interact to make feeding a problem. I think we know about the respiratory concern. You have a high respiratory rate, you're going to drag food into your airway if you breathe at the wrong time. We know that maternal factors are really important, not just the exposures, but to me, it's always really important when the moms haven't bonded and aren't present at the bedside when we're talking about preterm feeding problems, because that's when the babies really need them. It's no surprise that anybody with a neurological problem has some difficulty with feeding, and that doesn't matter what it is. It can be an acquired condition, can be stroke, can be perinatal injury, intraventricular hemorrhage. Any of those problems can interact to cause a feeding problem because it's so complex. These are kind of a no-brainer. If I would have been doing this slide myself, I would have taken the ankyloglossia off of this, but these authors included it. But I don't think that's a real issue for the vast majority of our babies. And I think that that would be fairly well received, except in the breastfeeding centers. Airway malformations, cleft lip and palate, and I'll show you a little bit of why cleft lip and palate are such a significant problem for a lot of our babies. And in part, that's because they are so complex. Gastrointestinal problems, of course, you know about the shortcut related to neck, but reflux and eosinophilic esophagitis are, of course, significant factors as well in your population as well as mine. And the babies who have gastroschisis or omphalocele have really terrible gastric motility and intestinal motility in general, and often are very prolonged in their feeding transition. Any metabolic problems, that goes along with neurologic or genetic as well, but these authors included the babies with low birth weight and IUGR as well. And all of those factors together bring us the long-term medical conditions, the growth failure, and the chronic feeding problems. And you could substitute in here airway problems and come up with this slide, use this slide and the talk that Jeanette gave as well. And then our ICU setting itself is a challenge to learning how to eat. There are lots of environmental challenges. You all know this. To me, one of the biggest factors in the difficulty in transitioning for the babies is the lack of continuity of the feeders in the setting and the very different style that different people have when they're trying to feed a baby. You don't want a feeder who can feed anybody. You want a feeder who says, okay, I gotta stop now, because we can all pour liquid down a baby's throat, but the babies who are pushed are much more aversive and get into much more trouble. And we all experience this, that we have difficulty in accessing parental support for the babies, and that goes in NICU setting and PSCU setting as well. And even though the feeding problems are so common, we don't have a consistent way to identify what actually is the core reason for the vast majority of babies, because it's this complex interplay of maturational patterns that impacts them. And the significance of feeding challenges is often underappreciated. I often get a call, it's just the feeding keeping them here. And I realize that's difficult when they've been through so much, and feeding is all that's keeping them. But the problems persist into childhood, and there are some studies coming out now about the impact of infantile feeding problems on life in general in adults. So why do we as a feeding team get asked to see the infants? Well, usually it's the OT seeking interdisciplinary or multidisciplinary collaboration. If they're having trouble with feeding the infants, they often will ask to broaden the team. And getting our team involved means broadening the team for them, because they just don't know where to go. And you're right in asking, why is it OT in Manitoba? That is a local quirk. Some centers use SLPs, but Toronto doesn't, Ottawa doesn't. There are many centers that use OTs like we do. It may be a Canadian thing. Influence of co-occurring conditions. Often the OTs aren't understanding what is it that of all of the complex conditions that the babies have. Is that there, Rob? No. How do they interfere with feeding? And that's where the medical portion of our team may be needed to help sort those out. The concern of aspiration is always a big consideration in whether or not we get consulted. But the vast majority of time now, we're getting consulted because people are asking, do they need a home NG? And that's been a complete shift in process over the last 5 years. We didn't used to send really small babies home NG fed, and we do now. So that's been a change in practice, and I'll tell you how we make that safe. So what I want to do today is to hopefully articulate some of the challenge that babies face, to describe the basic principles of the development of eating. We're going to talk about feeding on CPAP, and we will talk about thickening feeds. We'll look at the important steps to make a discharge safe, and then talk about a few other things that are related if we have time, like reflux and apnea during feeds. So the challenges faced by preterm infants in the transition to oral feeding are many, and yet sadly, well-tested feeding management strategies that we can generalize to all the babies aren't there. And that's really surprising when the problem is of such magnitude. So infants develop oral feeding skills on the backs of central pattern generators that they have in their medulla. And they have a lot of immature physiological processes that all need to interact in order to develop the nice feeding pattern that we'd like to see. And even though there are such challenges in that coordination, and we often trivialize the feeding problems, feeding is, I would venture to say, the most important developmental task that infants face, especially before they leave the hospital. And it's perhaps the most complicated. So a few fast facts here. We're going to talk primarily about bottle feeding here, because much of our understanding of newborn feeding is based on bottle feeding that provides a consistent effluent of fluid. We don't have that with breastfeeding, and we just don't know as much about breastfeeding and the mechanics of it as we do for others. And we have to remember that the very low birth weight infants don't have the same feeding skills at an age-matched level in the third trimester. So if you have a 23-weeker who is now 37-week, they are not feeding like a 37-weeker. And again, something that you know. So how does all of this mature? Well, let's talk about sucking first. So an infant must accept the milk with suction and expression of the nipple. So they have to latch first, and then they have to accept that process. Then they have to activate the musculature and automatic closures. So what happens is the tongue is actually a very powerful mover of that milk. So it grabs the milk and it slams back. It actually is physically pushing the food back. At the same time, the palate is rising to seal it off. So we have the airway passages both sealed off with tongue so that the baby can't breathe during that time. That's what's supposed to happen. But newborns can't always activate it at the same, all the same time. And that's why we get a lot of spillover in the nose or spillover out the front, because they know they can't coordinate it as fast. So then they have to, after they activated the automatic closures and raised the larynx and levered down the epiglottis and pushed the bolus, then they have to coordinate that with the breath. And they're not good at that at all. And all the while they're trying to keep the food out of their airway. They're trying to minimize their energy expenditure, propel the bolus into the stomach through the esophagus, and all of that with overarching neurological control. So you know where I'm getting at. It's not easy. It's not easy to be a 27-weeker. We start swallowing at about 12 weeks. We start sucking at 18 weeks. And somewhere in here, we start non-nutritive sucking. And that's a very different process from nutritive sucking. You go slower when you're non-nutritive sucking, about 2 sucks per second, and we don't need to coordinate anything. So infants can be standing on their head and do non-nutritive sucking, but it's harder to do the nutritive sucking because that relies on the central pattern generators of the medulla that foster the rhythmicity and the coordination we need. And you really can't do that till you're 32 to 34 weeks when you get better at it. So let me show you this swallow study while we're talking. I hope it's muted. This is one I did a few weeks ago. And this is a normal swallowing study going on here. So the infants latched onto the bottle. We're creating a really nice V pattern here that we always want to see, that V here, because that means they're containing the bolus. So the tongue is up, the palate is sealed, and they're pushing the food down. So they're sucking it, they're sucking and expressing the bolus. There's nothing residual remaining here that can spill over into the airway, and they've got it figured out. So they lower their mandible to create a bigger capacity in there. They close off their nose so you don't get the spillage. Newborns, preterms are often very sloppy with that, and you get nasal regurgitation. But if you get nasal regurgitation, you have to remember that the airway's only closed in the split second that we trigger a swallow. In that split second, we're expecting the bolus to go past. If your nose is full of milk, that can fall into an open airway. So that's why here it is again, you get the nice V for containment. When in the reports we say it's contained, we've got good containment. We're triggering off the back of the tongue here. We're propelling it through the esophagus, and we're not getting a lot of stuff sitting there. We have tight closures, so we can't breathe. I'll show you some breakdowns of these slides of this in a second, so you'll see it frame by frame. So when we're learning how to suck, we need to balance our suction and our expression, and that develops a mature, and that is what the mature pattern is. But newborns don't do that, especially small preterms. They learn how to express first, so they're actually just milking the nipple like they're doing with non-nutritive sucking. So they're just gnawing on the nipple, as it were, and they can bottle feed without suction, but they can't breastfeed without doing that without suction. So in a bottle, it'll drip. we use these bottles with the valves in them when a baby doesn't have any suction, like they don't when they have a cleft lip and palate, when they can't generate a suction. So then the bottles have a valve in it. That's one way the milk can only go forward instead of back and forth in the bottle. So you can bottle feed without suction, but not without extraction. Okay, now swallowing. Swallowing is, of course, the big problem. And the problem is in this phase. We divide it into oral phase, which we've talked about a little bit now, the pharyngeal phase, and the esophageal phase. And we usually don't worry about this, but it's actually really important, the esophageal phase. This is where the money is. So fortunately, in a baby, the airway is tucked under the tongue, right? We don't have it sitting like this, or we'd be even more trouble than we are now. So this is the vallecula and the airway, and they're tucked much farther forward in a newborn than in us. And that's why we would never chance doing some of the things that newborns do with their swallows. We would never do that. But newborns breathe at 60 and they will still feed. We would not do that because our airway is at the back of, it is behind the tongue, not tucked up under the tongue. So in the oral phase, if you make a mistake in the oral phase, then of course you affect this. If you make a mistake in the pharyngeal phase, you don't get it all propelled down the esophagus. And one thing depends on the other and relates to that. In the pharyngeal phase, there are really two phases. The flipping up of the tongue, the rising of the larynx, that's so important. And we talked about that a little bit with the tracheostomy. If you tether that, you can't raise the larynx, and then the airway is more likely to stay open. So if any of these phases are delayed, we're in trouble. And if the sucking occurs really rapidly, so it's very hard to fit all of that in. And I'll show you that right away. So this is a baby where this may be subtle, but there's already food here and there's food here and the milk is here. So this baby hasn't grabbed this bolus. It's been sloppy with the bolus. It's coming off the back of their tongue. With maturation, the preterms can handle more and more and larger boluses. Their swallow rate increases and their intrabolus pressure increases, so they can push that down better. When they're really little, they can't. So you get little pieces of food, little bits of food hanging out here right next to the airway. So you take a breath at the wrong time and you're in trouble. And you might have an apneic event, or you might have a major aspiration event very quickly. So this was the slide from the previous one, but this is the bolus not being held at all, and the baby not triggering a swallow. We should trigger a swallow from the back of our tongue. And that's partly chemoreceptors, that's partly reflexive, and that should trigger the swallow and it should go down smoothly like we saw. But here you can see the bolus is split and this is in the airway. And it's labeled as silent. This baby didn't cough at all to get that amount of contrast into the airway and without a cough. Here, the baby has penetrated the airway, but not aspirated. And you can see that again here. Here you see the vallecula, the space at the back of the tongue, and the epiglottis. You see that a lot more than I do because you intubate babies. So you see the epiglottis. This is the space where you're putting your laryngoscope. When we call it penetration, we see a little bit of contrast right below the epiglottis, but we call that penetration because it's not aspirated below the cords. So when we see a large volume aspiration, we will see an anterior and posterior on the tracheal wall. And it dissipates fairly quickly. And certainly not every baby who aspirates gets sick. In fact, most of the time babies don't get sick. And some of that is because we don't push them. But a lot of that is just because aspiration doesn't always make you sick unless you've got the perfect storm going on. So we don't actually know what the aspiration risk, we know the risk is high. but we don't know the incidence because we're not doing swallow studies on everybody, but it's high in preterms because they are klutzy and because of that differential maturation of all their processes from their sucking to their swallowing to their breathing. And it's seen in babies who feed well, and it's seen in babies who can't feed well at all. And the markers for that are very poor and very non-specific. And the question always arises for us, at what point are we actually going to do the swallow study? Because is this maturation, or is this going to go away next week? Then we don't want to radiate a baby brain, right? But if it's going to be there there because it's an anatomic problem, we want to do that swallow study as quick as possible because we want to know how we can remediate there. The esophageal phase, I mentioned that we don't think about it very much. This gastroenterologist, who's a neonatologist as well, has written a fair amount on this, Gencherla, about the esophageal phase and how we don't pay attention to it enough. He talks about no single symptom or sign being specific to esophageal pathologies. And his biggest concern is that the esophageal sphincters at the top of the esophagus, of which there are two, don't open fast enough. And that's why we get the pooling right above the airway. So not only do the automatic closures not happen fast enough in sequence, the esophagus may not open. So you may have a significant amount of milk right next to an open airway. And of course, the airway opens as soon as the baby takes a breath. So they can get in significant problems. There's a very characteristic pattern that you see on a swallow study when a baby can't open their sphincter. I've only seen it once. In 40 years of doing swallow studies, I've only seen it once. And it's a very characteristic sign. And the baby, that was a neurotypical baby who was in our NICU who could not open her esophagus. And we never knew exactly why. She outgrew it. She had a G-tube by a year. She was feeding fine, but for the first few months, she could not open her airway. Okay, breathing. This is where the money is for you. And you know these problems are really big, but we know that you need to be oxygenated well to feed because feeding is a huge aerobic cost for a baby. And as the feeding processes and the respiratory processes mature, they fit together better. They can breathe better. But here's where we have to remember. So a baby, a respiratory rate at 60, you're not chuffed about it. I'm getting nervous about feeding a baby at 60 because I know it takes 0.7 seconds to complete a safe swallow. So if you're sucking at one suck per minute, how are you going to get all that in? And you may get it in for 5 swallows, but if you don't stop and take a breath, then you're going to be in trouble. So you're going to miss that 8 and you're going to be in trouble. So you don't get a lot of time for air exchange if you're breathing at 60. Less so when you're at 70 or 80. And I can guarantee none of you would take a sip of water if you were breathing at 60. Because you have such a small window to take a breath. So we know that the minute ventilation actually decreases when we're feeding, your expiration time increases. So we have a little less time for air exchange, which can be a problem. So all of this, the development of the functional swallowing and aerodigestive tract protection is a continuum. It's modified over time. Time is the biggest thing we don't have enough of in the nursery when it comes to breathing, when it comes to swallowing. The factors are modified and they're all of the systems, the brain, the airway, the respiratory system, and the foregut are all involved in this. And the lack of coordinated activities is what gets us in trouble. And the coordination of these activities will ultimately lead us to feeding readiness. So at 26 to 29 weeks, a baby does a 1-to-1 suck-swallow ratio, but they don't do as many as a term baby does. So they need longer times to feed, but that longer time to feed makes them tired. And if you're feeding longer than 20 minutes, your aspiration risk increases because you're so much more likely to make a mistake. And preterms swallow at the wrong part of the swallow cycle, of the breath cycle. So that by 2 weeks of age, they know when to swallow. And once a long, long time ago in the dark ages, I did a study of looking at breath swallow patterns in infants, in 3-year-olds and 5-year-olds, and the swallowing breath cycle pattern matures until we're about 15. And then it's downhill after that. So we get better and then we get worse. So I'm bad now, but at my age, but it gets better and better and better. So I'm going to ask you, when do we swallow in the breath swallow cycle? When do we swallow?
And in between inspiration and expiration. So after inspiration is completed, I would try.
You might, if you think about it, it's not going to work.
During inspiration.
During inspiration,
Yeah.
most of us swallow during inspiration. We anticipate that the food is coming. We take a breath, we take the food in, we stop and swallow. But we swallow differently when we do liquids than we do solids. With solids, we can swallow anytime during the breath swallow cycle. We're confident. That's why thickening works, and that's what we're going to talk about. Thickening normalizes breath swallow patterns, and that's why they work. There's problems inherent in that, but that's why they work. If you swallow any child with a disability, if you look at how they're swallowing, they're fine when they're swallowing solids. They're making mistakes with liquids, and that's what preterms do too. They make mistakes with liquids. We always breathe out at the end of a breath swallow cycle. You take a drink and you breathe out. We do that to clear our cords, okay? Preterms do not do that. They do not clear their cords. They're much more likely to take a breath in after they've had a busy swallow pattern. Swallow, 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 right? And drag the food that's not cleared because their esophagus hasn't opened, and they drag that in the airway, right?
I didn't get that.
Sorry, you don't need to. Serious. So we have a very defined, and each of our breath swallow cycles may be different, but they're always consistent from adult to adult. Okay, so in preterms, they're all over the place. And in people drinking from straws, they're different, and we drink differently from straws, but we don't have to worry about that in newborns. So knowing what we know, when is a baby ready to eat? Well, that's a $64 million question, because the readiness to do the sucking, the swallowing, the esophageal propulsion, and the respiration, all coordinated, is really very difficult to assess and know. So are there investigations and are there standards? And here's where the green food comes in, because we use green when we do the fiber optic evaluation of swallowing. And I do that with Judy Jones usually, and you can see the airway that you know and see more often than I do, but we use green milk so that we can see whether or not there's any green having entered the airway. And we really like doing the FEAS, which is the fiber optic evaluation of swallowing, because we can do it during breastfeeding. This baby's wearing the scope and is breastfeeding. The problem with it is that when the scope is here, it gets enveloped with the green foods. So we get a blackout or a green out. We can't see for a second, so we don't know at what stage of the swallowing the food has actually entered the airway. So we can see that with a video swallow, but we can't see that with a fiber optic evaluation of swallowing. But this has the advantage that it's no radiation, that it can be done for long periods of time to actually evaluate what's happening. And you can stress a baby a bit by looking at what can they do. We don't do that before we've done a detailed history and we've watched the baby eat, because that usually gives us most of the information we need. And then this repetitive ongoing assessment is so critical so that we can try to figure out what's going on and how can we get this baby home? Because that's always the imperative for us. So here's where I would value discussion on, because we can ask ourselves, so in preterm infants, when we know the risks of aspiration and with the knowledge that we have of chronic lung disease, is it safe to feed babies on nasal CPAP or on high flow nasal cannula? And I have this in the references, and you might want to look at this paper, looking at oral feeding in babies with respiratory support. And you're at an advantage because you can see my next slide, but let's talk about that a little bit. The answer isn't clear. And as in most systematic reviews, the authors say the findings are insufficient to conclude and that further research is required. And I think we know that, but I know our practice is that we do it in some babies. Should we do it in more? And I'm happy to stop for a second and talk about that a bit.
Actually, I'm one of the people who I can say, like, if I'm in lower settings of CPAP, maybe 6 or below 6.5, it's feasible to try, because I think the airflow is not gonna be cause any troubles in this kind of cycle between breathing and feeding. High flow, actually for us, we think high flow is okay. Like most of the times when we feel the babies, especially we're speaking of term infants who are on CPAP, and the only problem is that the CPAP is that preventing us from going on the oral feed. We sometimes shift to the high flow because it gives us much of free space, let's say.
Yeah.
We feel much more comfortable with when oral feeds.
I think that's the right answer, that it's highly variable and very patient specific. I don't think we can have statements that say it's always safe.
Yeah.
Or it's never safe.
Is it related also, like how much baby is getting as a volume, like it's a big volume or a tiny volume?
Maybe as soon as you need lots of time to feed, if you have a big feeding, then as I said before, your aspiration risk increases with the longer feeding duration. And that's why we're looking at short feeds often with the babies when we introduce it, because they're best the first 5 minutes of their feed. They're much less likely to be tired. If you add into that the aerobic activity that's needed to feed, then you could get in trouble earlier in babies who are on nasal CPAP, or it really depends on what's actually happening there, right? If you imagine, if you are having high flow or high pressure and trying to do the feeding, it can be difficult. Again, if you've got a good feeder and they're strong and they might do just fine. And people have looked at full-term babies who are now 3 months of age and they have bronchiolitis and they need high flow for a bit. And those babies feed successfully. But again, I think they've learned it already, right?
Yeah.
They've been feeding for several months. It's established. And they know what it feels like. And also by 3 months, we're not so dependent on the reflexive nature of the feeding, right? When the babies you're seeing, they are reflex driven and reflex dependent in terms of their feeds. They don't have a lot of ability to modulate how they're eating or how they're breathing because it's reflexive. Sorry, I was turned away from the screen. Hi, Molly.
Molly's next.
Okay.
Yeah. So I thought it was now pretty well mainstream that we were feeding on nasal CPAP since, and I'm blocking on her name, since the girl from Calgary introduced zinc feeding to us, and we adopted it, and I thought it would be mainstream.
Well, that's what I thought too. That's why I was surprised at this 2023 paper, because I thought they would come up with some guidelines as to numbers that we could feed on or numbers we couldn't feed on, because zinc was designed for that, and that was 2010, I think, that we adopted zinc. It's been a long time now, but what these authors in the systematic review specifically looked at was, do the babies feed faster if they're exposed to to feeding on high flow or on nasal CPAP, and they couldn't find a consistent response in the literature as to whether or not they actually fed faster if they were exposed earlier, or whether they achieved full feeding earlier. And secondly, some of the papers had very significant aspiration events in their trials, and hence they issued the caution that there wasn't sufficient findings to do this. I think that we will continue to feed, and I think one of the main reasons we will continue to feed is that there is such high variability in the population that we see, and some of them can do it and some of them can't. But if they really can't do it, I think we have to accept that not all of them can. Chelsea? Oh, sorry, Molly. Go ahead.
Okay, I haven't seen that or read that systematic review. Do they cite the Calgary study?
I think I brought it. I'll check quickly.
I won't ask any more questions. I'll lower my hand.
Okay, Chelsea, while I didn't bring my papers. I left them on my desk. Sorry,
We're good.
but I'll check that.
I mean, I think I
About
also,
70 studies that they reviewed in the systematic review, and it came up. I hadn't seen it either. It came up because I was Googling that. So Chelsea and then Deepak.
I also haven't read the study. It'd be interesting. I think though that it's going to be like places try to do trials of the jet ventilator versus conventional ventilator to see which one's better at first intent. And because there's so much, difference between the babies and center expertise, they can never find a consistent outcome. And I suspect that feeding on CPAP is in the same place. If you have a place that's used to feeding kids on CPAP and is careful and individualizes it, those kids will do well. If you have a place that doesn't do it, and then they just start feeding babies on CPAP, of course, it's going to be a bit of a disaster.
Yeah.
Anecdotally, I think what I've found is as we've, historically, when they started to approach kind of 35, 36 weeks, we really wanted them off the CPAP because we wanted to feed them. And I wonder if we, if they're more stable from a respiratory point of view on low CPAP, to me, I wonder if that's better than trying to feed them in unstable, like when they're respiratorily not supported. So I think we've been a little slower to wean them off our low CPAP when we're like, okay, we can feed them, so there's no rush.
I agree with you. I think that that giving them some respiratory support and trying to mitigate the risks of aspiration is more beneficial than weaning them down just so that we can feed them and then they do a lousy job of feeding. So I agree.
And then we don't miss that window, right? Like I've always been taught, and I hope it's correct, that you really need to start feeding them during that late preterm window, because if you miss it, late preterm, early term, and don't start, especially like kids with bad BPD, if they're 41 weeks when you try to start introducing some oral feeds, you've kind of shot yourself in the foot.
You know that literature better than I do, but certainly that's what we see anecdotally. But you'll see in the review of the kids from our institution that the majority of them do learn to feed even with late exposure. So I'll show you those slides shortly. Deepak?
Yeah, I was just, I think we had a baby recently who was 42 weeks corrected and was still on CPAP. And I think when they're on CPAP, I think probably in the protocol somewhere it says feeding protocol that you shouldn't be going beyond sync D, like as a general rule. And in this baby, like the baby was doing well on CPAP, we were weaning, the baby was quite irritable, wanted to feed more. So then we kind of progressed beyond sync.
That's only on this side of the river.
Yeah, and I was going to say it varies between the two sides, where at St. Beat's more lenient, and I have had babies who are ad-lib demand feeding on CPAP.
Yeah,
So,
the sync specifies the amount though, and I couldn't remember the level at D or U that they're on, and that's not very much. But I think we have to individualize the protocols and we have to make sure that they're safe. But further research is probably still needed. So I just wanted to refresh our memory about aspiration and how common it is, even in babies who have bronchiolitis at 2 or 3 months of age. And some of our literature on thickening that we'll also talk about right away comes from the knowledge that if you have bronchiolitis, you are much more likely to aspirate, and that's in neurotypical kids who haven't had any chronic lung problems. So that's kind of an interesting phenomenon. We know that aspiration is more common in adults with chronic lung disease. We don't know if that's just because they breathe fast or because they actually hit their peak of swallowing safety when they were teenagers, and it's downhill from that there. And the aspiration is pretty common at preterm. So, and it can delay discharge. So we want to be conscious of that and cautious when we're introducing different feeding mechanisms, but allow some flexibility so that it can occur in infants who are capable. So should even the babies who aren't feeding, should they be allowed to practice learning how to feed when they're on CPAP? And I think they should. Some centers do fairly extensive oromotor training when the babies are on CPAP. And if we remember that oral feeding is a learned process and that we need to harness those central pattern generators that allow us to suck and swallow, I think the feeding training and end training, whether it's using non-nutritive sucking or not, is still very valuable in those babies on CPAP or on high flow. I want to briefly touch on reflux because we blame everything on reflux in Children's Hospital. I think we probably do on your side of the overpass as well. But the evidence that it causes harm is actually pretty scant. And we know that in preterm infants, they do have a hyperreactive laryngeal response to chemoreceptors. And that may cause apnea and bradycardia, as you know, which is one of the main things that delays it. We also know that it doesn't make a difference whether we position them, left lateral body position, head elevation, which probably is contraindicated, and feeding regimen manipulation. None of these seem to work for preterm infants when we're talking about reflux. And we know that pharmacological intervention likely causes harm. And it has been shown that it doesn't decrease apnea and bradycardia. So it's something that we don't use a lot here, but we're unique in the world probably, because I think they add it to the water in a lot of neonatal units. We do have to ask whether or not it triggers apnea and bradycardia at all, but most studies have shown that reflux episodes and apnea and bradycardia are rarely temporally associated. And one study even, I don't know how they got this through our IRB, infused saline into the pharynx of sleeping neonates. And it accelerated their swallowing, but it didn't cause any apneas and bradycardias. And these authors postulated that you actually need to stimulate the larynx to cause the apnea and bradycardia, and that shouldn't happen with small amounts of reflux. So take it as it is. These are the new guidelines for infants by Rosen et al., who is an aerodigestive specialist, actually. If you see any papers by Rachel Rosen, read them. They're usually very well thought through. So she has an algorithm as to how to approach it, and mainly that's an outpatient and an inpatient thing, but is a useful practice. So now we're getting to the intervention. I was going to tell you give a 5-minute stretch break, but I think we'll just power through and we'll get this done so that you can all have a little bit of your day back. So feeding interventions, I think for me, the most disappointing in doing this now for 40 years is that there is no consensus and there are no guidelines, and it's all trial and error. And every member of a multidisciplinary team actually views the problem through their personal lens. So I might view it through my lens of the medical complications of aspiration, whereas the OT is looking at positioning and bottles and drip flow. And if you had an SLP, she might be much more interested in the tongue mechanics and that sort of thing. So we all use our lenses when we're different lenses, but if the divergent maturation is at the heart of feeding problems. So if we need to mature our suck, and we mature our swallow and mature our respiratory processes, then the main thing is that we need to slow everything down. And that's what we see doing over and over again. This isn't so much about slowing down, but I thought I would include it here. And there is some evidence that infants latch much better if preterm infants, if the mothers are using a nipple shield, and that's something that we maybe don't use enough. Or they have a better latch, and they probably have more consistency of flow in the small reservoir that's created in the nipple, which is what in part improves bottle feeding as well. So had I remembered for you to get a glass of water for this section, I would have shown you that any motor activity requires a stable base, and that's why we wrap babies. If you try to drink with your feet in the air, with your hands twisted, and try to take swallow in extension, you will choke. And that's why we need to provide the position. You know this, but this baby is well supported in this position, as is this one, in a sideline position. And this simply mechanically slows the flow. We don't get the hydrostatic pressure so much of dragging the food into the mouth, and we allow a baby to take it a little bit more of a controlled way. We also mechanically slow the flow with these bottles. You know how these work? Yeah. So what happens if I take the green thing out? What happens if I take out the
It'll
vent?
be free flow.
To come like without baby sucking.
Is it harder or easier to eat
Easier.
without?
It's easy.
Can you explain it? We
Easier.
always hear it in Rollins, Dr. Brown.
Okay.
Dr. Brown.
Dr. Brown. I'm sorry.
That's what I thought. That's why I thought I'd shoot. This vent equalizes pressure from inside the bottle to atmospheric pressure. If you don't have a vent, you create a vacuum in the bottle. The vacuum prevents the flow. So the baby is sucking harder and harder and not getting anything. So if you want it to flow, you use a vent. It makes it easier for the babies to drink. There are other vented bottles. I'm not advertising for Dr. Brown. We happen to have these. Okay. The other reason we use these, so sometimes you'll see the OTs taking this vent out because it's still flowing too fast. And how do we know it's flowing too fast? The milk is spilling out of the baby's mouth. They can't keep up with the flow. Even you've got an extra preterm nipple, ultra preterm nipple on there, and it's still flowing too fast. So we put the vent on, and it flows the same as, it flows out the way it would if you're drinking from a cup. No atmospheric pressure changes. You take the valve out, you create a vacuum in the bottle, you make the baby work harder. So traditional bottles make the baby work harder. If you have a baby with BPD, you don't want them to work harder. You don't want to add aerobic activity to them, right? Okay, now what's the other thing with these nipples you can have? The reason that we use the other reason we use them is because we have a much greater variation in flow rate, because we have ultra prem, level 0, 1, 2, 3. So we have a wide variety of bottles. And then we have the vent tube for a baby who has no suction pressure. So that's why we use these bottles, because they are a one-stop shop. They cost about $9 for the set. We have no way of sterilizing them. So this is what we're stuck with. The families will get the bottles in the room, but it's a great expense for the hospital because the regular bottles are free. So, but because we have no effective sterilization there, what's in the room goes with the families. So it's not like there aren't other bottles, but that's why we use these. We're mechanically slowing the flow. And the other thing that happens is the bottle is vented. If the baby stops sucking, it stops flowing.
Okay.
When you have pressure changes, when you've created a vacuum, that may not be the case, because when the pressure is released and air all of a sudden rushes in, you can get a big gulp for the baby. that they're not expecting, and because their suck and their swallow are linked, they're gonna get in trouble. So those are reasons why we use the Dr. Brown. There are other bottles. This one is specifically designed for a no drip system. You don't want the hydrostatic pressure of a bottle. You know, if you have the bottle tipped in completely and the baby's on their back, you're gonna get a lot faster flow, which you don't want. This is a no drip bottle. We don't use these kind of things because we can't trial them and throw them away. They're expensive, they're $25 each, so we use the Dr. Brown's. This baby is using one of those no flow bottles and no drip bottles, so when the baby stops sucking, hopefully the milk stops flowing so we don't overwhelm their systems. And that's when we get into talking about thickened formula, because that is a mechanical way of slowing the flow and a very predictable way of slowing the flow for babies who may not be able to control that. And it's something we haven't used in this hospital since 2011. Do you know what happened in 2011? Well, the FDA and Health Canada on the May long weekend, so almost exactly 12 years ago, said that thickeners were dangerous to preterm infants because in the previous year, 15 babies had died of necrotizing enterocolitis post-discharge. So these were late onset NEC. The babies had been discharged from hospital, discharged from the NICU. And I can tell you that in 2011, we used a lot of thickener. But interestingly enough, we still don't know if it was the thickener, whether there was a contamination in the plant, or whether or not it was the xanthan gum, that thickener was the one thickener specifically that was implicated, that was called Simply Thick, and we used it like water, but it diluted breast milk, which always made us very nervous, and it's an additive to a formula. In this paper, which I also put in your references, they used the inherent qualities of the formulas that are used for babies, so they shouldn't spit up. It's called Enfamil A+ thickened is one of them. There are other brand names that are used in the rest of the world, but that's the one we have. And that is thickened. They take out some of the lactose and put in rice starch. So the calories are the same, everything is the same, but the inherent viscosity of that product is actually quite a bit thicker. When we look at viscosities, they are graded by centipoise, and traditionally 0 to 50 centipoise in a viscometer is thin liquid. This is about 25, so it still is what we used to call thin, but the new International Dysphagia classification system has added a category called slightly thick, specifically for this formula. So any rice starch thickened formulas, they are pre-made, and when you make them as directed, they give you a viscosity. And this study used the pre-thickened formulas that are a little more viscous, but otherwise are nutritionally the same. There are no preterm formulas like that, but they used them and they found that there was a significant improvement in oxygen desaturation and bradycardia in preterm infants. That has been shown multiply. The problem is we don't know if it's safe. And all infant formulas, all infant thickeners still bear the label, other than this one, which is the one again we use in our hospital. They all bear the label that says do not use under 1. Some of them say do not use under 3. And that goes back to the 2011 problems with infant thickener. This gel mix is a carob bean gum product. It's been used in Europe for a long time. They say it's safe 42 weeks post-menstrual age. If you look at the safety papers, they actually were only tested to 52 weeks. So I don't know what to tell you about that, but it makes me nervous, and I have not reintroduced thickener use in babies under 44 weeks ever since 2011. But I think that it might be something we need to talk about because there are also risks in some of the other things we do. So how do we balance that? And unfortunately, nobody's studying this because of the ban from the FDA and Health Canada. So I'd be happy to, we probably have a few minutes for questions here. I'm just about done. Okay, so the way the thickening may work is it may decrease the gastroesophageal events, reflux events, which may be hidden causes of why we have some problems in some babies. And we know it works for infants for sure. When we add thickeners to food, it works in children with neurodevelopmental problems when we're tube feeding them. If we use real food, it decreases their reflux symptoms. It does work, and probably because of hydrostatic pressure effects. When kids reflux, they dilate their esophagus, which may cause some central apnea because of the chemoreceptors in the airway. They really stretch there and get a vagal stimulation. So people have postulated that maybe that's why you get improvement when you have when you use a thickened agent. I think it works primarily because I think you improve your coordination of suck, swallow, breathe pattern, and that's why it works. The problem is that we just don't do it very often anymore, and we'll have to wait for more papers and more safety stuff. The paper that I showed you, they only looked at the safety during hospitalization. And I think that our practice has been that we don't do a swallow study before 44 weeks unless we think it's an anatomic problem. And then we'll carefully consider thickener if the baby improves their swallowing pattern, if we use the thickener during the swallow study.
Gina, why don't we just, like, I know in the breast milk fed kids, you can't use like pablum, but like, why don't we use it in formula?
Well, we can use this. Gel Mix is marketed for breast milk and formula. We just don't know if it's safe. We can use them. I preferentially use the pre-thickened formula because it does not bear a safety warning. It's the only thing that doesn't bear a safety warning because it has been used, but I wouldn't use it before 44 weeks in the preterms either. Just because it's not been studied.
Okay, yeah, it is. I remember it's a huge transition. It's like when they took cisapride away.
Yeah, the cisapride probably worked. None of the other things have worked since, but it does have a pretty high side effect profile. So yeah, that was the age when we used a lot of the thickeners as well. So it may be that we get some studies on the gel mix that show us that it is safe. People think the carabine gum may be safer, but if the mechanism of the neck is that it slows gastric emptying, or that it affects gastric emptying or intestinal emptying, I'm not sure how we're going to show that. None of the babies who got neck were over 44 weeks gestation in the 2010 problems. So we are almost done, but we talked about buying time. We talked about buying time as slowing things down and about using bottles, about using position, about using thickener, may or may not. But the main way we've been buying time, and that is using home NGs. And that's been a big change in practice over the past, I would say 10 years. And the reason I have this slide up here, it's called It Takes a Village. And I want to show you the village that it takes to send babies home on NG and some of the safety mechanisms that we've built in that make it safe. So who lives in our village? In the village here at the hospital? Well, we have the inpatient feeding service. We have our nurse, Christy. And then we use whatever OT or rehab assistants or RDs are on those units to build a feeding team. So like Jeanette talked about building a tracheostomy team, we build a feeding team by available services on the ward. We liaise with the surgery team every week. Every Tuesday morning, we have rounds with them. We talk to consultant teams regularly as well. So we look at all of the factors that may be implicated in sending a baby home with NG feeding. This is our outpatient team. Besides Jeanette and Kyle and Vera, who are the doctors on the outpatient team, we also have a couple of OTs who work very part-time. And because they work so part-time is one of the reasons we have difficulty discharging all these babies, because we don't have a lot of the supports that we might want to discharge them effectively. But we have 3 dietitians sharing 2 EFTs, and our outpatient nurses, Aislinn, who also does the teaching for the home parenteral nutrition. So these are people plus me are the core of the Manitoba Home Nutrition Program, which you are consulting. That isn't the same as feeding clinic. These 3 people, these 4 people plus myself are the Manitoba Home Nutrition Program. And we also provide formula and supplies for children who don't have a third-party care, which is another issue. But so when I looked at who was entering our village of tube feeders, I reviewed the last 100 consults a few months ago, and 62 of the children that I was consulted on were less than 3 months of age. A quarter of the 100 were preterm infants. For the most part, they were complicated children. If I looked at the numbers of systems involved, they had 3 or 4 systems or specialty care involved with them. 81 had feeding skill deficits, and there were some aspiration issues. And tube feeding issues are very prominent. 72% of all of those were about tube feeding, either existing or arranging being very prominent. But look at the difference in what we've done in terms of statistics of babies discharged from the hospital with enteral access in these years. So this is COVID, during COVID times, but we decreased our gastrostomy placements by quite a bit, and we increased our NGs by quite a bit. And we started discharging kids to more remote areas, to rural Manitoba, to remote Manitoba, and to Northwest Ontario. So we were able to decrease the GTs, which has been the wish of many centers, to decrease the GTs, because like other places, we found too that a lot of the babies were using their GTs for very short periods of time if we said they couldn't go home with NGs. So we realized we needed to make it safe, that we needed to address whether the communities could support home NG, what happened if caregivers got into trouble, and should it matter where you live? Should you be non-dischargeable just because of where you live in Manitoba? So a number of authors have shown that it's pretty safe to discharge babies on home NG. So again, a high N number with 200 of them going home NG, no complications. Similarly with this one, and again, a Rachel Rosen paper. And we have had no readmissions for NG failure, which is much more than we can say for our G-tubes. So what we set out as sort of requirements for our home NG program was that the babies needed to be 37 weeks post-menstrual age. You may have moms in the nursery saying their babies are 34 weeks, they've heard about home tube feeding, let's go. But we can't do that, in part because we cannot support that on the babies going forward. We cannot see them every week. We always see them within 48 hours. We contact them within 48 hours and we see them within a week, but we can't double our numbers to do that. So we need them stable. We need them gaining weight, stable on their home support. They have a safe oral feeding plan. Sometimes that oral feeding plan is no oral intake, but we do need a plan because the moms can't be counting respiratory rate. The moms can't be introducing which bottle and which flow and what position. And we don't have the OT support to do that. And they can't have an anatomical variation that precludes safe NG feeding. I know you guys all often will put in orogastric tubes, but in a baby, the flick of a tongue dislodges that tube. It's really not as stable as a nasogastric tube. And in some babies who have this configuration, we really worry about the stability of the tube and therefore the safety of it when we're sending them home. So this could be very hard to insert. It's even, sometimes we put it in the nose, but there really isn't tissue to hold it there. And we do worry about those children. We do sometimes send them home, but we do spend a little bit of time worrying about it. So if you're feeding into the esophagus, you could get into trouble. So what makes it safe for our team and why we've not had any kids come back with NG failures is we need these prerequisites as well. The parents have to be engaged at the bedside. That's really hard, but if you can't get the parents to come in to visit their baby, they're probably not going to come in to learn how to do an NG feed. In fact, that may scare them away. But we have engaged with several families who have been very difficult to feed, to engage, and sometimes successfully done. They need really good teaching to be safe. They need a supportive community at home. And the parents have to be able to come for follow-up. And we've actually introduced that they need to have a way to contact them. They need a phone. Because we can't be chasing them around all the time and never being able to find them. And if you're taking 75% orally, you don't need an NG tube. We don't need to give them that last quarter. Those kids who are taking 75% orally, we probably need to challenge them or concentrate their feeds or decrease their volumes, but look very carefully because they shouldn't require home NGs. The other thing that makes it safe is all the investment that our nurses spend in with the bedside team and with the parents in making the parents independent with NG feeding. They can't go home if they're not independent with the GT, with the NG measurement, placement, verification, maintenance, and to have a protocolized feeding plan. And we published this in 2019, and ASPEN, which is the American Society for Parenteral and Enteral Nutrition, basically adopted our hospital plan, of which I'm very proud of. So what happens when the babies go home with NG feeding? Well, the parental satisfaction is high, and even the moms who are really worried and really nervous, they generally are very comfortable after that first insertion that they've done themselves. The time to oral feeding, this was written by a person who, Benjamin White, who was a newborn fellow when he did the papers, and he has about 3 of them. And then he's no longer a neonatologist, go figure. But he found that in 14 days, 40% of the babies were on oral feeds, time to full oral, and 80% by 6 months. A similar number by Khalil et al., 5 months by Rosen, this is a different Rosen. And we found in our group that 60% of the kids used their NGs for less than 21 days. And we had a very small conversion rate to GTs. So we think we actually are onto something. On average, our babies use their tubes, their NGs for 102 days, so not that long. And I think it's a tribute to the follow-up and the organized program that we have in following them. So I just want to show you the GTs in comparison. So we're an average of 65 a year now, having this significant decrease in 22 compared to 2017. But the children who go home on GT feeds, they have a much higher incidence of emergency room visits. They have more complications than kids who are on NGs. And it saves a ton of money to go home NG because it costs about $50,000 a year to support a baby with a GT. It's a really expensive process. And the first year is probably the most expensive, and the year in which most of them will wean as well. So these are just some numbers that I thought you might be interested in, because we used to only send home babies with GTs, even if they were living remote and far away. So quickly to recap, we know that feeding problems are really common, that they delay discharge. And they're likely related to differential maturation of the processes that are integral to feeding safety. Despite the commonality of how common these problems are, we don't have any clear guidelines for intervention. There are some controversial topics that I think bear some more looking at. We know that G reflex may be a significant contributor, but is probably overrated in terms of its significance. What may be more important is the esophageal opening and the sphincter issues that happen at the top of the esophagus than the bottom. We know that home NG allows time for the maturation and the integration of the process, but it needs to be safe and really well structured. So with that, I hope that we've gone through the objectives that we set for today. I can forward the references that I collected for this. There's a couple of slides, so I'm happy to share this with you, and hope that that feeding is something that captures everybody's imagination, as it has mine for a long time now. Thanks very much.
Sure.
I have one question, a simple one. For babies like with bronchitis or maybe TTN, where there is no significant, like let's say, work of breathing, and they are just like technique. We usually we ask or we order, like it's something I think it's just like anecdotal by us. We allow for oral feeds if the respiratory rate is less than 70. So when the nurse asks for something more,
Right.
Does that make sense? Or
Well, you can just get your swallow in at 70, right? Because a swallow takes 0.7
exactly,
seconds,
open, yeah, exactly.
right? So you can just barely get it in. If you're 3 months old, you're probably doing 3 sucks and then a swallow.
Yeah,
If you're brand newborn, you're doing 1 swallow, 1 suck, 1 suck, 1 swallow.
yeah,
So you can probably not get it in. If you're a bigger child, if you knew how to eat before and you have bronchiolitis, you might be able to do it. But if you're really sick, you can't do it.
exactly.
You can't do it.
So for NG, like which size of NG you are?
For home, they all get 6.5 French, and they get polyurethane tubes, not polyvinyl tubes.
Okay,
In the nursery, you're usually using polyvinyl tubes
okay.
that have a 3-day shelf life. We use the polyurethane tubes because they're softer, but 6.5 is what we use, and they last for 30 days.
Oh, 30 days, okay.
So if the baby's not pulling it out, that may be the only tube they need.
Mhm.
But
And if accidentally the tube is
the
out.
parents
then-
have to put it in. They have to
Okay.
learn how to put it in. That's why there is such extensive education, because we don't want them sitting in emerge. Emerge goes ballistic if a baby is sitting there for 8 hours waiting for an NG to put in. So the parents have to learn, and they have to be completely self-sufficient, making sure they know how to measure, how to place, how to make sure it's safe. And we use pH, and that's been shown to be one of the safest way to confirm, besides an X-ray, but that's not realistic at home.
Okay.
But recently, a paper was published that showed that pH was valid in, they did 95,000 pH testings in an NICU. And though we think there isn't a lot of acid there, most of the babies had the pH of less than 5, demonstrating that it was in the stomach.
It's just following this question. Actually, we do the same thing here, like inside the hospital, but when we do the X-ray, like in a good bunch of times, we find like the NG tube not just in the stomach, it's stuck between the esophagus and the stomach. And really, I'm concerned with the family, they encounter similar problem, but it seems like you are not encountering any kind of
No.
emergency visit for that, which is.
No, we're not encountering any, but we tell them that if they don't get a proper pH, they have to remove the tube and put it in
a
again.
new one.
Mhm.
No, not a new one. It's
Oh,
valid,
that's
it's good for 30 days.
Yeah.
They're expensive, they're
Yeah,
$50. So we don't tell them to throw them away. If they're under 30 days, they reuse them.
Oh, really?
Yeah, they wash them with tap water and reuse them.
I have one question, but I don't know if it's like, but there is a kind of intervention related to the electrical stimulation of the hypopharynx or pharynx.
Yes.
I wonder if it has any role, like, because I never heard about anyone for babies got
Well,
advantage of it, but
The I wish we had something. I'm certified in doing that. I've done the courses and I know how to do the electrical stimulation. But there has only been proof of concept in terms of safety and using it, but no one's ever demonstrated that has any positive effects.
Cool.
And I wish we knew, because it would be an intervention that could be offered, but it's not been validated other than showing that it's relatively safe.
Okay.
And that's one paper from Toronto, 10 people, 10 children. So it's used a lot. Some centers use it a lot.
So frequently, especially when they say, okay, it's a micro aspiration, a little bit of coordination thing, let's get some benefit. They give 10 sessions or something, and it seems
I
to be
wish.
useful.
I wish it's not been, there are no published papers on it. And like I said, I wish there was. LA Children's uses it a lot. There are some centers, it's easy to do. It's
Yeah.
not hard to do if the baby isn't instrumented. It's worse if there's a vagal stimulator or a VP shunt or something, you're not going to do it. But basically you apply electrodes and you while the baby is feeding, you drive the muscles that make them feed. So if you could drive the tongue or you can drive the masseters, but it's very uncomfortable when during the course that I did, when they did it on me, I didn't like it at all. But yeah, some centers use it a lot, and I wish it was that simple. We did a small pilot here. We didn't have any trouble doing it. We had some successes, but when we look at how complicated feeding is,
Yeah.
which of those
Interventions.
interventions
to be
have we
implemented.
actually affected, right? So I think it's more complicated than just driving the muscles. And I was very optimistic when I went to do the course, hoping that finally we would have some intervention. And then, but like I said, I've talked to people who have done it as well, and we can't find any validation. Some people have looked at it in stroke in adults. Again, if you dig down into the statistics, it's very difficult to say that this was because of the neuroelectrical stimulation, or was it just
It could have
improvement
been,
in the
just
stroke?
something complementing to the whole
Exactly.
approach.
Yeah. Yeah.
One, the last question is about the terminology. I have used to her about micro aspiration, macro aspiration. Is it the same thing about penetration and this kind of?
No,
No.
aspiration means it's below the cords for sure. It's just in terms of quantity.
Okay.
And I think people use microaspiration when the baby isn't coughing, choking,
Okay.
you know, those kind of things. But again, the terminology is not,
Terminology,
it's
silent
not
aspiration,
uniform.
penetration, micro-
Silent aspiration is because most children actually do not cough when something's in their airway. And we don't know why that is, why children don't cough. Like most of us cough like crazy, except smokers don't cough because they're so used to particulate. No, they're so used to particulate matter in their airway that they don't cough. When you inject their airways, they don't cough. So babies who are smoke exposed may not cough because of they're used to being in a smoking household. But that's
So do you think that our endotracheal tube has done the same thing? Like, do you think that's why ex-prems don't cough?
Exactly.
But it could be that they've desensitized their trachea. People talk about desensitization of the trachea. It could be that. I don't think we know that. Sensory factors and chemoreceptors are, our understanding of that is even worse than other things. But like years ago, I read a paper that, you know, feeding the baby bolt upright is better because you get less nasopharyngeal stimulation of the chemoreceptors. So you should feed them bolt upright, or even in almost a semi-prone position, which makes it really hard because they don't make angled bottles anymore. When we had angled bottles, you could do that. But the chemoreceptors, I think, are going to be the story of the next decade of trying to figure out how we can get those, harness the potential of understanding those. And the vagal triggers, I mean, the vagus is everywhere, right? And it impacts so many of the processes, and we just don't understand it all.
What do you use for this green color things that you.
We actually use Kool-Aid, and we use one
Kool-Aid.
drop of Kool-Aid
Oh,
in the milk. Yeah.
it's working.
Yeah.
Looks like working.
We used to use methylene blue, but methylene blue colors the liver blue. So why that matters, I don't know. Most of us wouldn't know if our livers were blue, but so people don't use it medically anymore.
Yeah, that's why we were using to understand the gastroesophageal reflux, some methylene blue in the past.
Yeah. But methylene blue is no longer used for these
Looks like it's much
purposes.
easier. I can buy from.
It's much bluer, it's much bluer, but
Just to kind of wrap my head around the concept between Dr. Brown, so it's exactly the opposite of a slow flow nipple. You want the baby to exert less energy trying to suck.
well, it's counterintuitive. We want them to, we want to flow control.
Okay.
We do want to flow control, so that's why we use the nipple flow control.
Mhm.
But we don't want them to be sucking so hard against a vacuum
Okay.
where they, so we're trying again, find the balance.
Mm.
So we want a bottle that doesn't pour out when the baby lets go of the nipple, because it collapses the nipple. They've been working so hard. If you use a closed system,
Mm.
they suck, and then all of a sudden, oh, and their mouth is all full and it's pouring out, right?
Mm.
So you don't want that, but you also don't want a nipple that if you invert the bottle that it pours out,
Mm.
right? So you add flow control, but you take away the pressure.
Okay.
I don't see anymore, like too much this finger feeding kind of strategy.
Have you
They
ever
all-
tried to do it? Have you ever tried to do it?
I told my nurses.
It's
Okay.
very hard to do, mechanically very hard to do. And it doesn't, again, if you're tying a tube to your
Yeah.
finger,
Yeah,
that milk is pouring out because you've hung it on a bag, right? It's not respecting the infant sucking, holding, and triggering a swallow. The milk is pouring in,
okay.
but you may not get that baby may not be able to handle that flow.
Mhm,
We used to do it all the time.
mhm.
I've tried doing it and I think I need a third hand to do it. It really is very hard to do, to actually hold the baby and get it dripping and then pace them so it doesn't flow too fast, and it's really tricky to do.
It's the same thing, like, also there's another technique to put.
It's the same thing, it just pours the liquid in.
Okay,
The ENT surgeons used to do it for babies who were drooling, or for children who were drooling, they relocated the ducts. Then it just falls into an open airway,
mhm.
because we only close our airway in that split second when we trigger a swallow. So this milk is flowing, whether the baby's sucking or not. And in a swallow study, I've seen it, if we take out that bottle quickly, because we want to stop the flow, and the baby's still got milk in there, they will aspirate that milk if they stop sucking, because the airway opens when they're not triggering a swallow. So I think it's dangerous to do the unfettered flow into the mouth. I think it's a dangerous way to feed.
And then I have one more question.
Sure.
Like, I was evaluating some projects from the nursing side. There was one project was assessing a with the tiny microphone to put here with the swallowing quality of, is it like a?
I've done that. I actually have, many years ago, I published a paper where we put a recorder here and here.
Okay.
So here you hear the breath sounds if you put it on over the trachea, you can hear the breath sounds and you can hear the coordination of the breaths on the swallow. You can. You need a computer engineer to sort out the sounds because there's so much noise
Okay.
in the sounds. And here you primarily hear the sucking.
Okay.
So here you hear the sucking and here you hear the breathing and the sucking.
Oh,
So you can do that, and it's been done. That's.
okay, so they are putting here, I think I know.
You can put it there,
Mhm.
but you have to ask what you're looking for, because it has been done multiply in the 90s when people were looking at swallowing And that's how we did the study, looking at the different viscosities and the maturation of the swallowing and the breast swallow pattern. So it would depend on what they're asking, but certainly can be done with an accelerometer, but not the easiest study to do because of the noise that you get that needs to be canceled out. So you need to have an engineer on the team to look at the computer engineering, to look at getting the data clean.
And Dr. Rempel, I had a question. So sometimes we have we have some babies who are very stuck, sometimes not progressing on sync, and in them it's a bit more clear cut. Okay, they probably need like a feeding tube to go home. We also have babies who are very chronic, who are like maybe 40+ weeks and who are very slowly progressing. And like we almost feel like if we wait a couple of more weeks, maybe the baby might get to full feeds, but the parents are getting more frustrated, right? And they want to go home. So have you used that scenario to send babies home on feeding more from a parental perspective, that it's better for the baby to be home?
Yeah, it is better for the babies to be home and they do learn pretty quickly. I have no trouble with them going home like that. But I think that what we need to respect the outpatient team and getting, how are we going to advance the oral feeding? So I'd like to at least have in writing, what is the parent going to do at home? If the baby's breathing at 70, well, we can't expect the mom to count the respirations. How are we going to advance the feed? Or are we going to say 10-minute time limit? We're not going to use sync in that situation. We're not going to use sync. In fact, I think sync, we need to abandon sync earlier when it doesn't work and just get a structured feeding plan. They're going to feed for 10 minutes or this volume, or we're going to allow 5 minutes when they're efficient and they're not going to tire out. I think we need that kind of structure because otherwise the outpatient team just can't keep up with the demand that we are putting on them for getting these babies home. So, but if they're stable, there's no apneic events, they're growing, they just need some time to allow the maturation processes to occur. Yeah, those are great candidates to go home. The ones that are the hardest are no oral feeds, and we're sending them off to northern Manitoba, and the baby's not doing anything. Well, how are they going to learn how to feed? You know, so those are the ones that trouble me more because we can't get them into clinic on a weekly basis. And it is really different seeing them on Zoom versus seeing them in person. So I always worry about what I'm doing to the outpatient team. We may be able to do it safely, but how are we going to progress them in the absence of having a structured team that's actually looking at them on a daily basis? So, but yeah, they do better at home and there the parents have to care for them. And sometimes we figure, oh, they'll be back because they don't get it. And then they're not, which always surprises us. So the parents do develop some resiliency to allow them to stay home, I think. And we've had babies who we have struggled with getting the parents to the bedside here in NI. And then those babies go home and their first clinic visit, they're off tube feeding. And we think, well, if you had only been here, if you'd only been in the nursery, maybe we could have sent you home like 2 months ago. So I think that I wish we had a way to engage the parents. And I think sometimes all our interventions make the parents overwhelmed and make them scared of us. I don't know. I don't know all the reasons, but I sure wish they were there. It would make it a lot easier for us to engage them and get their babies home. But
Thank you.
So, sorry, I have one more question. Oh no, it's 3:29. How does the turn it off again? Did you try turning it off and back on again work? Like sometimes the kids that aren't progressing, you're like, feed them NG for 48 hours.
yeah, that's oral aversion. That's oral aversion. And I think that's how that works, is we aren't demanding of them. We're not demanding something they can't do. So the reset, I think it works. And something I haven't tried, but I know it's reported, is also using cold formula. Again, because of chemoreceptors and triggers. and that they may trigger faster, which is something that our nurses would probably go ballistic if I asked for a bottle of formula from the fridge. But if their temperature is okay, then it might be something we can try. Certainly cold therapy is something that is used a lot in adults, so it's something interesting. If you see me ask for it, then that there's no evidence, just it's anecdotal, and I know that's not data, so but the reset, I think, works for some kids. It doesn't always work, but it's worth a try. I think part of the reason we need resets is because of the variability of the feeders. We rarely need resets in the babies whose parents are at the bedside. Okay. Thanks so much.
No, that was fantastic.
Yeah.
Thank you.
Thank
Thank you. Thanks a lot.
Okay, bye-bye.